Thank you so much, Giuseppe. Thank you, Dr. Abdallah, for understanding. So my topic for today would be to discuss about the role of pharmacotherapy to prevent sudden cardiac death. And I will start saying that it's quite a very difficult topic, and we know several things. Let's say the incidence of sudden cardiac death is related to functional class, and patients with lower functional class had high incidence of sudden death. We learned from MEDIT 20 years ago. We know that nothing changed in the last 2 years. We have a complex interaction between cardiovascular substrate, neurohormonal activation, and triggers. And also, considering ejection fraction, maybe it's good, maybe it's not good, maybe we will replace 5 years after researching with LGE, let's say fibrosis, magnitude of fibrosis, distribution of fibrosis. But for this moment, ejection fraction, it's one of the best discriminators related to incidence of sudden cardiac death. We know exactly this picture because this picture is very intuitive to select between primary and secondary prevention of sudden cardiac death in patients with heart failure. And we know, and we are still at the beginning, we are very primitive, let's say, in understanding mechanism of sudden cardiac death, particularly in patients with diabetes, patients with heart failure. And at the end of the day, it's a long, long story related to receptors, channels, and PAMs. And just to have some kind of didactical models related to action potential, related to channels, and we have here a clear example how to intervene related to sodium channels, to potassium channel, to calcium channel, to ATP pumps, because the influence of this type of channels, pumps, and receptor, it's translating in longer or shorter duration of action potential, early or late post-depolarization, which are very, very inductive of malignant ventricular arrhythmias. But let's stay back again and to think about, and this is from didactical model to reality, because we are linking, and at least in our perception, ischemia to arrhythmic death. But the patients with acute coronary thrombosis may die not only because of left ventricular arrhythmia, may die probably because of cardiac rupture or cardiac tamponade. And we should think about, when we are thinking about all-cause mortality, because all-cause mortality is a very, very complex. In the structure of all-cause mortality, it's entered cardiovascular and non-cardiovascular mortality. And cardiovascular mortality is pump failure and sudden death. What type of sudden death? Because, as I told you, patients may die from sudden arrhythmic and sudden non-arrhythmic death. And it's also very important which component of arrhythmic sudden cardiac death can be prevented by electrical therapies. So let's try. Think about Fantastic Four. Fantastic Four are for heart failure with reduced ejection fraction. In heart failure with preserved ejection fraction, we have only one fantastic, and this is SGLT2 inhibitors therapy. Also, again, coming back, there are many, many differences considering mechanism between heart failure with reduced versus preserved ejection fraction. Mode of death is different. Look, and this is probably the larger experience. It's South Korean experience from South Korean registry showing the difference in mode of death. between patients with preserved versus reduced ejection fraction, and also mechanism of death. And this is important when we address a patient based on cutoff of ejection fraction to know mechanism and mode of death. However, this may introduce a lot of confusion, and we should be very distinct how to analyze. Because mode of death, cause of death, and terminal event are different terms reflecting different understanding of sudden versus arrhythmic versus preventable arrhythmic death in patients who died from heart failure. So in this way, we should classify interventions in patients with heart failure as interventions who will decrease both all-cause mortality and sudden death mortality, intervention who will decrease all-cause mortality and are neutral on sudden death, an intervention who will decrease sudden death. You mentioned yesterday CAST study, and CAST study was a very pedagogical example showing that treating frequency and complexity of ventricular arrhythmias with anti-arrhythmic drugs has been associated with decreasing of the incidence of arrhythmia, but doubling the risk of all-cause mortality. So let's have a short review. I will start with neural receptor antagonists. Neural receptor antagonists, and we have till now 3 meta-analyses, including 4 and other meta-analyses, 5 studies with neural receptor antagonists, decrease the risk of sudden cardiac death together with risk of all-cause mortality by 20-23%. This is important thing, but pay attention to the last meta-analysis, and this is important. The effect of neural receptor antagonist on sudden cardiac death, it's very dependent of beta blocker dose. So this is a very important tool when you try to introduce in patients with chronic heart failure, sequential therapy, profiling, but Professor Rosanna reminded me yesterday about order. We don't have a clear order, but it's better to introduce neural receptor antagonists after beta blocker therapies. For ACE inhibitors, we have 3 analyses, meta-analyses. This is Marcus Fleder's meta-analysis first, showing that ACE inhibitors are decreasing all-cause mortality. We don't have, except last 5 years meta-analysis, analyzing type of death, but look, ACE inhibitors, angiotensin receptor blockers have no effect on preventing sudden cardiac death in spite of huge benefit on all-cause mortality. There is some evidences only for army, but take care how to interpret this kind of evidences, because I showed you meta-analysis. This is post-hoc, even predetermined analysis from Paradigm AGF showing that therapy with sacubitril/valsartan, it's decreasing sudden cardiac death. For beta blocker, 4 meta-analysis, huge benefit on all-cause mortality. It's a class effect, and also on sudden cardiac death, and this is very important. Benefit is between 30 and 35% for decreasing sudden cardiac death. For SGLT2 inhibitor, it's an excellent putative mechanism. There are many explanations to show that this kind of therapy is decreasing sudden cardiac death. And I will start saying it's again post-hoc analysis from DAPA-AGF, showing that dapagliflozin in patients with heart failure, regardless of diabetic status, it's decreasing the incidence of atrial arrhythmias, atrial fibrillation, and atrial flutter. And this analysis, this is also very recent, show a signal of probably positive benefit of therapy with dapagliflozin in patients with heart failure and reduced ejection fraction and incidence of ventricular arrhythmias, but pay attention to differences between investigator-reported and then adjudicated. So dapagliflozin decreased the incidence of arrhythmia when was investigator reported, but no finally adjudicated. Two meta-analyses, two very recent meta-analyses showing that therapy with SGLT2 inhibitors, DAPA and EMPA, are decreasing the incidence of atrial arrhythmias, but no effect on incidence of sudden cardiac death. And this is the second meta-analysis, no effect on sudden cardiac death, in spite of, this is the last meta-analysis showing some kind, but this is post-hoc, has no statistical power to assess the difference, statistical difference. This is post-hoc showing that at smaller doses, we don't know exactly what does it mean, smaller doses, the effect of SGLT2 inhibitors on sudden cardiac death were positive. So this is the scheme showing benefit of fantastic four, actually four, on sudden cardiac death. And except this therapy, other therapy like PUFA, like class 3 antiarrhythmics are neutral or even deleterious on sudden cardiac death incidence in patients with heart failure. We have this New England Journal showing decreasing incidence of sudden cardiac death, and currently annual incidence of sudden cardiac death is somewhat 2 to 4% per year, so it's a real decreasing of incidence. And this incidence, decreasing incidence, was associated to guideline-directed medical therapy benefits. This is true, and but when we look at the sensitivity analysis, year of publication didn't matter too much, so the effect of ICD is still significant on arrhythmic sudden cardiac death. And I will finish my presentation showing the incidence of sudden cardiac death in patients with cardiac resynchronization therapy, and you'll see significant decrease in incidence of sudden cardiac death in this patient. This effect may be attributed to introduction of beta blockers. This is true. Selection of lower risk patients in terms of age or ejection fraction or QRS elevation. But finally, when you look at the gap between incidence of sudden cardiac death between CRT and CRT-D, you'll see that CRT-P patients are protected by sudden cardiac death by remodeling effect. And this is an important concept. I don't believe in proarrhythmic effect of cardiac resynchronization therapy. And at least look at this study. It's repeated, it's reproductive, showing that reverse remodeling was associated to decreasing the incidence of sudden cardiac death. Probably in the future, new algorithms to predict sudden cardiac death, arrhythmic death, preventable by ICD, electrical arrhythmic death will improve risk stratification in these patients. And we should agree that ejection fraction is not a good discriminator, but is the best in this moment. Thank you so much.